Welcome to the Cafe Clinic podcast, where health meets high vibes.
Hello, Jagat. Nice to see you. Hannah,
Hi, sir.
where are you posted now?
Sir, in the emergency medicine.
Emergency medicine. Both of you?
Yes.
Okay, since how long you are there in emergency medicine?
So for 1 week.
1 week?
Yes.
For you?
Sir, same.
Say 1 week, or you are in the same group?
Yes.
Very good, very good. So you must have seen a lot of a medical emergency by this time, is it not?
Yes, sir.
Okay. So you must be having something there in your mind to ask, because we have emergency physician, we have a pharmacologist, myself a physiologist, and we have a medical education expert here from physiology itself. So you'll be possibly having some doubt, from the patients that you have seen in the last 1 week. Speak up.
Sir, I would like to ask him. So I just witnessed a road traffic accident victim being rushed into the casualty. And I noticed all the doctors and nurses surrounding him, monitoring him, and administering the treatment urgently. And they all look so concerned. And I'm quite curious to know what happened.
Certainly, this is an excellent experience to learn from it. The patient is actually had a road traffic accident. He's a 28-year-old boy, and he brought into the emergency department. On examination, he was restless and anxious. His extremities was cold and clammy, and his blood pressure was around 70/50. Pulse rate was more than 130, and his respiratory rate was more than 32. And his urine output was quite low. And he also had a laceration of thigh. And based on these conditions, what do you think about the diagnosis?
Sir, I think the patient is in shock.
Excellent. It's a shock patient. And can you narrow it down?
Sir, could it be hypovolemic shock?
Excellent. There are 4 types of shocks are there. Distributive shock, obstructive shock, hypovolemic shock, and cardiogenic shock. This patient had a quite big loss of blood loss. And this patient comes under the hypovolemic shock. It's quite a hemorrhagic shock. And let me call our physiologist to explain the basic pathophysiology behind it.
Treatment. I think I hope the patient came around. He's back to life.
Yes, sir.
Yes, excellent. So slightly we rewind back to our first year.
Yes.
And we know that our body is just like a watermelon. It's not.
Yes.
We have a lot of water. You know that actually an adult person, a male, is having 70% of our water. Is it not? And the water is distributed in different compartments. Is it not?
Yes.
It can be in the intracellular compartment. It can be in the extracellular compartment. And extracellular compartment water can be in your intravascular compartment or outside the blood vessels. We call it as interstitial compartment. So what I want to say that the amount of water in all these compartments are very important. So what actually happened to that particular poor boy here? He lost blood from the intravascular compartment. So it's a body fluid compartment. Is it not?
Yes.
So we know that the body is always trying to do all the mechanisms possible to keep the life back to normal, and all your microenvironment, like your internal milieu, you know that, to keep in a constancy. Is it not? And what we call that particular mechanism that is happening in the body to keep the microenvironment constant? Homeostasis. So this is actually a typical example of malhomeostasis. There is some dearrangement. What dearrangement? The body fluid compartment is getting shrunken. The blood volume is getting lost. So what the doctor should do first? To replenish the lost blood.
Yes.
Is it not? Otherwise what will happen? When the blood volume is so severe, and it will go into a vicious cycle or positive feedback. And what will happen? Whatever treatment that we do, we may not be able to bring the patient back to life.
Yes, sir.
And all positive feedback system will act one after the other. And your negative feedback mechanism to bring the BP back to normal become ineffective. There is the role of our doctors. Is it not? That the reduced cardiac output should be brought back to normal. The reduced blood volume should be brought back to normal. You know the relationship between the blood pressure and the cardiac output. Cardiac output into peripheral resistance is your blood pressure. And you might have seen all the clinical features Dr. Ajit was narrating. Is it not? Based on which you made a diagnosis of hypovolemic shock. Is it not? What are the important clinical features? He said There is an irritability and confusion. Patient was restless and all. What could be the reason? Because body is trying to cope up. The sympathetic system becomes overdriven.
Yes.
You know that the body becomes restless. So he will be throwing hands here and there. For what? To increase the blood volume back to normal. Actually, your muscle pump is put into action.
Yes.
So what the doctors who should give advice to the bystanders, don't restrict them too much. Allow some sort of free movement here and there. Usually what we see there in the bystanders, they will get so panicky and they will try to restrict them. Somebody will be holding the leg, somebody will be putting the hand in a restricted state, but you should not do that. Allow them to have a free movement. The body is trying to pop up the venous return and to increase the blood pressure. Another thing, pulse rate increases. 130 is not this. 130, tachycardia, again sympathetic drive. And what happened to the periphery? By feeling the periphery, he felt
Cold and clammy.
How? The circulation to the periphery is reduced. Why? Because of vasoconstriction. You may be having a rationing. Is it not? The cardiovascular system is so choosy. Cardiovascular system needs which are the circulation to be effective, which are the circulation is not that essential to keep the life. Your splanchnic circulation to the gastrointestinal tract and the cutaneous circulation, is that essential to maintain the life? You tell me. It's not required. Yes. So what cardiovascular will do, will take away the blood from those areas and will pump into those areas which are required for the life. Which are those areas? Your cerebral circulation and your coronary circulation. That's the reason why you are having a cold and clammy extremities. Respiratory rate was increased. Why? Because there is a generalized hypoxia, decreased oxygen supply to the tissues. Tissues cannot survive without oxygen. So what will happen? The lung will put into action, respiratory system will put into action to the maximum to take away the oxygen from the lungs to the tissues. So you got all the pathophysiology behind the clinical features. It's not.
Yes.
You know the reason behind tachycardia. You know the reason behind the pale and clammy or cold and clammy extremities. You know what will happen to the urine output. Proportionally, the blood flow into the kidney also affects reduced urine output. So all these clinical features is having a physiology background based on which you are making a diagnosis. So please be under the illusion that physiology that you have studied in the first year, you are going to apply in your clinical scenario based on which you are making a sensible diagnosis. Okay, so I think the management part, the treatment part, they have actually given intravenous fluid, they have given so much of drugs and all those things. I think the pharmacology professor who is here, she will be telling about the pharmacology behind it.
So, in patients with shock, I've seen the legs raised up. So, what's the reason behind it, sir?
Excellent observation. In a shock patient, you usually try to lift both legs so that we can maximize the venous return of the patient to the heart. So his cardiac output is usually maximized. In this trauma patient, usually will go for a ABCD approach. A for airway, B for breathing, C for circulation, D for disability, and E for exposure. In airway, ensure the airway is patent and the breathing is quite normal with oxygen supports. In circulation part, we will put 2 large bore IV lines and we will try to maximize the IV fluids. Up to 1 liter of IV fluids we can give. After that, we will try to give blood products like fresh frozen plasma and packed cell blood. Okay. Even after the resuscitation part, if patient is having hypotension, we will try to give vasopressors like noradrenaline and vasopressin. Okay. Then we will go for disability and exposure, where we will whether patient has any other external bleeding, and we will try to contain the bleeding with the surgical intervention part also. And based upon these management parts, I think based on the drugs we used, our pharmacology will explain how these things are acting on the patient.
Thank you, sir. Now I'll briefly explain about the pharmacological management in hypovolemic shock. Sir already told about the drugs we are giving. First, we'll give intravascular fluids like crystalloids. The most common choices are lingual lactate and normal saline. Then we give these to expand the intravascular volume, to improve the venous return and increase the cardiac output. Next, we are go on with the blood products. First, we give packed red blood cells. First, it increases the oxygen carrying capacity of the blood. Then we can give with fresh frozen plasma, which improves the clotting factors. Then we can give platelets which corrects thrombocytopenia. Still the patient is bleeding. The best drug we give is tranexamic acid, which is an antifibrinolytic agent which inhibits the platelet activation. This drug has to be given within 3 hours of trauma. At this point, you must titrate the intravascular fluids and you must see the patient is hemodynamically stable, and you should identify the cause of bleeding and you should address the surgeon for surgical intervention.
Excuse me, ma'am. So, what if the patient is still unstable? What will be the treatment then?
Okay, nice. Next, first we go for vasopressor. Here that vasopressor we are here dealing is norepinephrine, which is an alpha-1 agonist and beta-1 agonist. Its main mechanism is vasoconstriction. It increases systemic vascular resistance and also increases the cardiac output. Then we can go with vasopressin, which is an V1 agonist. This also causes a vasoconstriction, thereby increasing the BP, which makes the patient hemodynamically stable. At this point, we must see the vitals and we can go on with surgical intervention if needed.
Okay. Thank you.
Being the pioneer of physiology, I would like to ask you, can you explain about the golden hour, sir?
Thank you for the compliment. I'm not a pioneer. But I'll tell you one thing. The golden hour is actually not telling so many important medical emergencies. The timing of arrival of patients, the transportation of patients from the site of injury or site of the medical emergency to the management, it's very, very, very important. Now, you may be knowing that all the regulations that you have studied in your first MBBS level, how the body is immediately responding to increase the blood pressure back to normal in a 3-tier manner. Is it not? So, immediately what mechanism will come? The neural mechanism will be coming. Because the neural mechanism is so fast in response. All the reflexes that you have studied to increase the blood pressure back to normal coming under the neural, they are very fast in action. But the problem is, as they are so fast, but they may not be accurate enough. So first thing is your baroreceptor reflex. You have sensors in your different part of your circulation which are constantly monitoring the blood pressure. You know where are they located? You know it. They are in the arch of aorta and in the carotid signs. They are nothing but the baroreceptors. They are stretch receptors. They are physical receptors, mechanoreceptors. They will sense, hey, there is a drop in the blood pressure. How immediately they will give the command to the brain centers through which are the nerves, glossopharyngeal and vagus. You may be actually seeing the diagram behind the reflex arc, where you have a receptors, you have the afferent tract, you have the center, you have the efferent and the effector. Here you have seen the receptors are baroreceptors, afferent are glossopharyngeal and vagus. The center is nothing but your vasomotor center of your brainstem. The vasomotor center will assess the situation. It will immediately send the command through sympathetic system, both to the heart as well as to the blood vessels. Blood vessels undergo vasoconstriction to increase the peripheral resistance. Heart will be beating fast to increase the cardiac output. Both components are raised to increase the blood pressure. But it has got its own window period.
Yes.
If it goes beyond that, what will happen? Your baroreceptor becomes ineffective. Your baroreceptor reflex or the vasomotor center becomes non-efficient to sense the BP drop. Then your chemoreceptors will come. But mind you, the nature is so good and it will never ever lose the hope, just like as we do.
Yes.
They are actually still hopeful. They will try to bring the life back to normal. Chemoreceptor reflex will come. You know the pathway. Chemoreceptors of carotid bodies and aortic bodies send through the signals to the same nerve to the vasomotor center. Vasomotor center will get activated. Sympathetic drive will come to the heart. This time, it is much more aggressive because VT is dropping down below 90 millimeter of mercury. Life is not possible. So what will happen? Not only the heart and blood vessels are the target, adrenal medulla also release adrenaline and catecholamines to increase the blood pressure back to normal. So nature is trying its maximum to bring the life back to normal. Then last ditch time, what is that? Your CNS ischemic response. That also will come into the action to increase the blood pressure because of lack of blood flow into the center by itself. So these are the 3 mechanisms neurally mediated to bring the BP back to normal. Once the BP is brought back normal, you need to have a long-term mechanism. What are they? All the mechanisms that you have studied through the endocrine orchestra as well as through the kidney are to increase the blood volume back to normal. Cardiac output back to normal. Your aldosterone is coming through renin-angiotensin system. You are seeing the diagram. Now you have the vasopressin system. The doctor said about the significance of vasopressin that we are giving as a drug. You know that body itself is having a vasopressin coming from hypothalamus to increase the blood volume back to normal. Not only that, it will cause vasoconstriction. So that will increase the blood pressure back to normal by increasing the cardiac output. It is much more long-standing and much more perfect. So the golden hour, madam was actually telling about, we are allowing our own body to act properly in a timely manner to bring the life back now. What will happen if you are missing this golden hour? All these reflexes will be ineffective. Not only that, the body will go into a positive feedback of catastrophe. Your vasomotor center becomes paralyzed. No blood flow, no oxygen supply. The center cannot function properly. Center cannot sense. What will happen to your blood vessels? Blood vessels becomes lethargic. It will not go vasoconstriction. It becomes dilated. Then what will happen when the blood vessels are dilated in the capillary segment? All the blood will actually ooze out. You said that actually the doctors are giving intravenous fluid. Will it be going to be there in the circulation or not? It will not remain in circulation. It will go out. So there will not be any circulating blood volume increase. Not only that, your intestine is having a lot of gram-negative bacteria. So when your body is weak, they become dominant. They will actually release your endotoxins. You know that the endotoxins are vasodilators. They will aggravate the situation further. So one by one, and the cardiac muscles by itself, the long-standing hypoxia of cardiac muscles, they will not be powerful enough to beat. Everything put together, one after the other, it will go like a vicious cycle and a positive feedback. In a cascade manner, the blood pressure will drop down, and finally it will reach a point where we may not be able to
Revive the patient.
treat the patient, or we may not be able to bring the life back normal. We may lose the patient. Do you know what that condition called? When the shock is going into a state where we are not able to treat. What's that shock called? Exactly, the refractory shock. So you now know the role of a physician to act immediately in the golden hour. We are supporting the body mechanism to increase the blood pressure back normal. Is it clear? Perfusion pressure should be increased. The kidney should get adequate blood flow. Your brain should get adequate blood flow. Your heart should get adequate blood flow. These are the three vital organs which are responsible for maintenance of life. If one is compromised, it will add on to the other problem, and finally we lose the patient. So hope you have a panoramic view how a hypovolemic shock is so medical emergency, how we should act in a timely manner. If you are not acting in a timely manner, what will happen? Jagat, I hope you got everything about the hypovolemic shock, the management, the treatment, the progress, significance of the golden hour, the physiological basis, pathophysiology, everything.
Yes.
Are you satisfied? But I think you have got some doubt.
Yes.
Tell me.
Sir, we do so much about the refractive shock, yet so many patients they lose their life. And I have seen patients being administered IV cannulas in their neck region. So why is that, sir?
Dr. Ajit, now do we have any way by which refractory shock is intended? It is coming.
Yes.
So that the doctors or whoever are actually treating can be much more alert, much more aggressive. Is there any indicators by which we can say that the refractory shock is forthcoming?
Yes, sir. Usually in the shock patients, even after giving IV fluids and blood products, those drugs won't respond to the patient. So patient usually will end up in a refractory state. So in that scenario only, we will putting on the vasopressors like vasopressin and noradrenaline we are bringing into the picture. So since the patient has severe vasoconstriction in the peripheral vessels, usually we will put a central venous catheter in the neck. That, as our student said, we will try to give the vasopressors through the central venous catheter, and we also will try to put an intra-arterial line for active blood pressure monitoring. So these kind of invasive treatments also have part in the refractory shock management.
It's very true. I know. Actually, if you are keeping a sensor there in the peripheral circulation, already the peripheral circulation is compromised.
Yes, sir.
So there is no point in having a monitor. So exactly what he said, you need to have some cannula there in the center to get the central venous pressure, and also it will give you more idea about the circulation status of that particular patient. Exactly.
Yes, sir.
That was a very good question, Jagat. So actually that completes the whole discussion about the hypovolemic shock and the management. So now let us see what are the different competencies that we have covered in this brief discussion. Dr. Vijay, please.
As we conclude this cafe clinic, where all the four departments have come together and discussed about the hypovolemic shock, and here, as a MBO member and a physiologist, I observed that almost 5 competencies from physiology was covered.
5 competencies?
Yes, sir. And 6 competencies from pharmacology is covered, and 5 competencies from emergency medicine or general medicine is covered. So totally 15 to 16 competencies were covered.
15 to 16
Yes.
competencies are covered in this cafe clinic.
Yes, sir.
Good.
And this is just for the UGs, whereas undergraduate MBBS students, according to CBME, these competencies were covered. And this podcast or this cafe clinic also will be useful for the PGs, like general medicine PGs, emergency medicine PGs, surgery PGs, and also for the interns who are handling the patients in the casualty as emergency medicine, and also the other students like allied health science students and nursing students who are posted in the casualty. And this not just it connects the basic sciences like physiology, biochemistry, anatomy, and then it connects with the clinical departments such as emergency medicine, pharmacology. So it connects all the phases of MBBS, and this is a type of vertical integration or integrated teaching which the CBME or the NMC recommends. So this will give the students a total insight about how to handle or how to manage a patient of hypovolemic shock. So this kind of podcast has to continue, and we request you to provide your valuable feedback as well as different topics which you need us to telecast like this. We want your valuable feedback, and also kindly suggest the topics which we have to do it in the future. So stay tuned for more. Thank you.